can get to the Q&A section. Right, perfect. Okay, so thank you to all of our speakers. It was a very interesting session. Does anybody have any questions for them? Yeah, Dan.
So Dr. Lin, that's very interesting study, the trial, and I'm especially interested in seeing that moving the prescription dose from 30 grades to 40 really improved that outcome. So I just want to ask you, because those two different prescriptions didn't really show difference in toxicity. So I want to get your comment on how much do you think that the technology improvements has played in the dose escalation, and also with the current new methods to kind of improve the treatment, do you think there's more room, or also if it's necessary to further escalate the dose in SBRT?
Thank you so much for the question. I think that's very important. Number one, I think technology actually does matters, because when we were doing the 5-grade and 6-grade per fraction, that was 2007, 2008. And then when you escalate to the later, because the trial actually lasted for 6-7 years, and that could be because of the technology is better, because initially we were using BrainNap, and we didn't have a cone beam CT, and we were using basically it's even the imaging guidance was a 2D. So I also worry about that when we were doing that, we had some bleeding. I was thinking about that too. So I agree that it could be because of technology improvement affect that too. That's one question. The second question is that why would the higher dose of 35 to 40 is better than 25 to 30, other than the technology? I think that's probably to do with one is the local control, one is probably I will have to ask Dr. Lee whether those patients, because I found that most of the patients had the resection. They are all in the group of higher dose. So the lower dose one, conversion rate is very low. So that's probably the reason, because when you convert more patients to the surgery, they do better. Oh, but then the two survival line, actually, those patients are all without surgery. So again, so that will have to be the from the local control. Okay, and then what is the other question? I'm sorry. Oh, do we need to increase more dose? And of course, for the tumor, I want to go to as high as possible. But again, we have a dedicated normal organ surrounding. I don't think it's safe to go higher. And I have seen people are doing 50 grade in 5 fraction. And if those the area you want to give 50 in 5 is away from the small bowel, away from the stomach, away from all this critical organ, why not, right?
Thank you.
Dr. Batra?
Can I ask a question?
Yeah.
Okay. So I have a question for Dr. Lin. Particularly, your radionuclide immunotherapy trial using CA-125 antibody, where you although didn't find difference in survival between both the group, but you did find in 2 patients longer survival. The question is on this aspect. So what was the criteria for selection of patient for this trial, particularly when you introduce CA-125 antibody?
So the only criteria for patient who's getting that monoclonal antibody is the CA-125 10 unit per ml or higher. If anyone is lower than that, they don't get it.
Okay, So CA125 has a very high level of circulation. Antibodies targeting, so the whole purpose is basically it's a binding circulating antigen, antibody, and then presenting. And with that way, you see a very specific immune response.
Actually, yes, it's binding to the circulating CA125. And that's why I thought that that's actually very interesting results is that 2 patients, they actually received the 7 doses. That was designed 7 doses. Some other patient, either, you know, one reason or the other, they just don't get the 7 doses. They either get 3, 4, 5 or something. And these 2 patients actually get the 7 doses with a very strong immunoreaction and showing the CD8 T cells immunity. And those are 2 only patients actually survived in the whole group, the 31 to 31 months. I don't know how to explain that. I do think that that's a very promising result, and we can look into it.
So the original antibody is mouse or humanized antibody, CA125? Was it humanized antibody or murine antibody?
The VOMAT should be the one you can use in the human, right?
No, the antibody which you use for therapeutic purposes, was it a murine antibody or humanized CA125 antibody?
I thought it's a humanized. I'll have to check.
Reason this whole concept of combining was using murine antibody, not with a humanized antibody. The reason was people, when we started this is a 10-year-old concept, started at Iowa. When they gave a murine antibody, it was a response, and we always believed that mouse antibodies immune response is bad for patient, and in patient ovarian cancer, it showed a very promising result. So that was the reason, whether it was a murine antibody you use or mouse or humanized antibody you use.
Check.
Dr. Zhong?
So again, follow up on that question. Like, for those people who cannot get 7 cycles, what kind of toxicity, what issue prevented them from getting?
So, sorry, what's the question again?
For that trial, you only recruit 11 patients with anti-CA125 antibody. So why is a lot of people cannot get?
Right, so some of them, they just didn't get the blood collected, I think. And only 5 patients, 5 out of, I think 11 patients accrued, the 9 patients actually received the oligovomet. Among them, only 5 had strong enough to get this test. I think they did another test first, and then most of the patients all negative, but those 5 patients had strong enough for them to go on to have this, to test for CD8. I think it's also to do with sample. It seems like they don't just get a good quality sample or something.
Can I ask Michael or Dr. Batra another question? So when you figured out cholesterol synthesis pathway is important for radiosensitizing in pancreatic cancer, and you find that enzyme, the FDSP,
The FDPS?
FDPS is like involved. Do you think the actual effect is actually truly even more downstream, or if you go more upstream, would the effect being even better? Or is
Well,
there any branch?
let's direct that question to Dr. Batra. He can probably answer it.
My question is again for Dr. Lin, for my own understanding. In neoadjuvant therapy, you are used initially 5-FU, then you have used now GEM, and now more moving to the modified FOLFIRINOX. In all 3, and the standard practice is going to go for FOLFIRINOX. What your opinion is in future multi-center clinical trial?
again, this is not my field, but I have a question for Dr. Clutie. So nowadays, the people talking about immunotherapy. So what is the role of immunotherapy for pancreatic cancer?
It's a good question. So at this point, the only subtype of pancreas cancer where immunotherapy seems to be effective is in pancreas cancer that's MSI high or has mismatch repair deficiency. There have been several combinations of checkpoint inhibitors which have been tried in patients with metastatic disease and have been ineffective. Though there's a lot of work going into different combinations, ways to stimulate the immune system to try to convert these tumors, so that they could be responsive to immunotherapy. But so far, nothing looks so promising. And I'll add that, about 1% of pancreas cancer is mismatch repair deficient or MSI high. So it's, it's a few and far between to find these patients.
So Kevin, you asked question to me. The question.
Sure, that's okay. Yeah, I was just curious in terms of the cholesterol synthesis pathway, since you find that enzyme, which is like kind of showing differential expression after from the microarray study. Do you think is that the level that we should target, or going more even downstream or even go more upstream may have even better results?
Okay, so I'll give you the answer. Basically, cholesterol has a both good and bad effect. Some studies have shown higher level of cholesterol has a better survival. Some says lower has a better survival. So we did find those enzymes, but then we looked back in databases also, there was gene signature, particularly there were 7 enzymes which were more important than all pathway. It's not the total cholesterol which is making difference. It is this FDPS, which is intermediate of the cholesterol pathway. They cause modification of RAC and other permeation of the other downstream targets are getting affected. It's not the cholesterol total. Cholesterol total is good and bad both ways. So it is the intermediate of the cholesterol which is causing post-translational modification of other signaling protein, which is important. Itself has not only caused the effects on cholesterol, but it is also changing the tumor microenvironment, particularly is bringing the 2 other aspects, cancer stem cell as well as on infiltrating immune cell.
So in that case, the meta also work on the RAC1 protein as well?
Yes, correct. It is inhibiting the modification of RAC1 and downstream pathways. It was.
All right, I actually have a question for Dr. Lee. Dr. Clutie ended up touching on the reasons for doing neoadjuvant therapy for even resectable pancreatic cancer. I was just wondering what you see intraoperatively after neoadjuvant therapy versus actually operating on a de novo tumor, and what does that do as far as complications and difficulty of the surgery goes, particularly in light of, say, neoadjuvant radiation.
So interestingly enough, we find that there is no significant difference with neoadjuvant chemotherapy. That's given the patient recover from chemotherapy. But for the most part, we actually don't see a big difference in that. We do see a difference when the patient got radiation. It makes the pancreas a little firmer, and believe it or not, we actually liked it better because it makes it firmer, it's easier to sew.
Okay, very good.
So can I add to that actually? So there's been recently a paper that came out in JNCI, which talks about the effects of chemotherapy, and also there's another paper on radiation therapy. So how in pancreatic cancer that in prior to surgery setting, it is changing the immune cell infiltration and antigen processing machinery. So that does make a strong case actually of combining either chemo or radiation with immunotherapy. subsequent to like resection. So immune checkpoint and all those things. So there are changes which are occurring at the level of the tumor microenvironment, which may benefit other therapeutic modalities. So.
Yes, I have a question for you, Dr. Clutie, as well. So obviously with the SWOG trial and how it was designed, you can't really compare between the two arms, and comparisons in pancreatic cancer trials in general is hard. But with that said, there really was nothing in the data that you ended up presenting that would suggest that the Gem/Abraxane would be any worse than the neoadjuvant FOLFIRINOX, and it may have better toxicity profiles, at least based on the data there. So is there beginning to get to be more of a push to do neoadjuvant Gem/Abraxane versus neoadjuvant FOLFIRINOX?
I think so. There are institutions that love Gem/Abraxane, and there are places who, you know, kind of are FOLFIRINOX loyal. So I agree. I think this trial really kind of highlighted that Gem/Abraxane is a reasonable option. You know, oftentimes because we were worried about the degree of response with Gem/Abraxane, we would start FOLFOX and think about adding irinotecan if the patient tolerates it. But I think this kind of validates the use of Gem/Abraxane as a reasonable option. I think toxicity wise, I guess in my experience, FOLFIRINOX has a much broader range of toxicities, where Gem/Abraxane, I think, you know, tends to have less GI toxicity, but at the same time, it seems that patients tend to have more fatigue and more trouble with myelosuppression. So, you know, I think it kind of just depends on the patient and the scenario, their functional status, that sort of thing. But I think it's certainly a reasonable approach for neoadjuvant therapy.
Any other questions? All right, then I think with that, we'll conclude this section. I think we have a 20-minute break now, so we'll start back with the physics section here at 3:40.